Good morning. My name is Dr. Mulasheri Ajit Shankardas. I'm the Director of STEMI India and the Chest Pain Clinics, and the topic today we are discussing is thrombolytics. Now, thrombolysis means a medication which dissolves the clots during a STEMI treatment. It's also called as fibrinolytic therapy, and the potential benefits of a STEMI treatment with thrombolytic is time dependent. So, if you treat a patient early in the cycle of a STEMI, that means you move the patient from say C time to D time, by 60 minutes you get a 30% reduction of mortality. But later in the cycle, if you try treating the patient, say you move the patients from A to B, which is a 120 minutes or 240 minutes difference, you will get only a 10% reduction. So there is a critical time dependent salvage which is important for STEMI. While in this period, what you're really doing is opening the infarct-related artery by either reperfusion due to thrombolytic or by PCI, and keeping the open artery there so that the ventricle remodels. So, as I said, your in-hospital mortality of a fibrinolytic therapy is time dependent. If you give it quickly, your mortality is close to 7%, 30 to 60 minutes goes to 9%, more than 90 minutes is about 16%. So the most important thing in patients with STEMI when you're using fibrinolytic or thrombolytic is to give the patients an early reperfusion, and the drug has to be delivered quickly after diagnosis of STEMI. Now, what thrombolytics or fibrinolytics have been classified as fibrin-bound plasminogen specific lytics, which is 3 of them: alteplase, reteplase, and tenecteplase, which acts on the clot. And then there is a circulating plasminogen on which the non-specific ones act, which is streptokinase, urokinase, and anti. Ultimately, all this, what it acts on is the clot locally and systemically, and removes the clot from the artery and improves reperfusion. Now, the ideal thrombolytic is fibrin-specific. That means it acts only where the clot is and not systemically. It should have a long half-life. That means a bolus administration is possible. It should be non-antigenic. There should be no antibodies to this drug so that it's not reversed before action. There's a low reocclusion rate. There's low bleeding risk, and it is cost effective. We still don't have an ideal one, but many of the drugs we have today are good, and they can be usually very, very specific for the local clot. The indications for fibrinolytic is when primary PCI is not possible, and primary PCI there is a 120-minute delay. So, if the patient has ischemic symptoms and is less than 12 hours, the level of evidence is 1A guideline for lytic. If it's between 12 to 24 hours and there is a large area of myocardium at risk or hemodynamic instability, the level of guidelines is a little lower, it's 2AC, level of evidence is only C. And if there is ST depression except for true posterior wall MI, it's harmful. So don't lyse patients who don't have ST elevation and have ST depression. So clearly, we should not lyse patients who do not have ST elevation.